Hello everyone. Thanks for coming for the round. My name is Sameet Kumar, first year nephrology fellow. My topic for today's ground round is resistant hypertension and how we go to the resistant hypertension from the nephrological point of view. So today's for learning objective, I will just start with the define all the resistant, what is the resistant hypertension, and what are the prerequisites for diagnosis of resistant hypertension. And the second target will be to identify the secondary causes of resistant hypertension and explore the long-term effect of resistant hypertension in different organs of the body. And I will just, this is a wide topic. I will just focus on the 2 to 3 things that is most commonly seen in our clinics and in the inpatient setting. Most likely, I will focus on the primary hypertension-induced resistant hypertension, primary aldosteronism, and as well as I will focus on the resistant hypertension in the ESRD patients. And as far as I will also discuss the aldosterone receptors location, apart from like a kidney, what are the other locations that for the aldosterone receptors are located, and we'll discuss 2 to 3 trials that are ongoing trial for the resistant hypertension. So, as far as incidence, general population have the 12 to 15% of hypertensive adults have the resistant hypertension. And as far as the CKD concerned, it has been seen like 20 to 30%, 30% who have the CKD have also the resistant hypertension. And it's more common is the high incidence in the patient with ESRD patient have seen 40 to 50%. So before proceeding with discussion with regarding the resistant hypertension, I have a case. This is from my clinic case, so I would explain that. This is a 52-year-old man with CKD step 3B and blood pressure is around 176 by 102 in our clinic. He's on any 3 medication, losartan, amlodipine, chlorothiridone, referred to the nephrological clinic for the evaluation of the resistant hypertension. So this is the first time we have interaction regarding this patient. So I have to see about, is this information that is available is the good to diagnose this patient with resistant hypertension, or we have to need another more information to diagnose this patient with resistant hypertension, or is this a true resistant hypertension, or is a pseudo hypertension? So first of all, to diagnose this one, what will we do next? So when the patient came for the evaluation of resistant hypertension, first of all, we have to check about is this blood pressure is the true resistant hypertension or not. So I have one example regarding my clinic. So there is the one patient who came in my clinic for the CKD3 and who brings the blood pressure log with him, and he has a blood pressure line for more than 2 to 3 months and take just like a readings of more than hundreds. And all average blood pressure reading was 150 to 170s. But when I saw this patient in the clinic, their reading the blood pressure was 130s. And I rechecked him after 10 minutes, and it was 120s. So I was thinking about what's wrong with blood pressure reading at home. So it's showing about something is going on with her. So then I just asked him which blood pressure apparatus he's using. He said that he has brought like 3 months ago new blood pressure apparatus, and he has a very tight cuff. So this was the problem when the patient who has a very tight cuff, there will be a high possibility for chances the high blood pressure reading. And when the cuff is too large, there will be a high likely chances to get the blood pressure that is on the lower side. So regarding my previous case, so I have a one blood pressure reading that is in my case like 176 by 80s to 90. So I don't know either this patient has the white coat syndrome, or I don't know about the patient who has what about the blood pressure reading at home. I have no idea. I have to first exclude from the ambulatory monitoring of blood pressure, or I have to ask about regarding home blood pressure readings first of all. And after that, for diagnosis of resistant hypertension, we have to check about is this patient is on medication that has good like we have a criteria that at least patient for the resistant hypertension has on three class of medication that should be on maximum dose before diagnosing for the resistant hypertension. Or so So I would discuss regarding the previous case. So this is the case that I came to my clinic. I don't have idea. I will follow this patient like is this patient on the good medication, maximum dose of medication. Then I will decide either this patient has a resistant hypertension or not. So I have never good idea regarding the current patient what's going on with him. So just for overview regarding resistant hypertension. So the diagnostic criteria for resistant hypertension, the patient should have blood pressures more than 130, or at least 130 systolic blood pressure, and diastolic should be more than 80. And patient should be on 3 antihypertensive agents with a maximum tolerated dose. The most likely the classes of drug that should be a patient use, that is the one is a long-acting calcium channel blocker, that is a non-dihydropyridine receptors blocker. And other one is at least patient should be on AC or ARBs therapy. It's not criteria that patient should be either AC or ARBs. Either of them can be started. And a diuretics, that should be a thiazide diuretic. So from 3 classes, it's not mandatory the which class should be started first. It's randomly either first can be started diabetic, first can be started the ACR therapy, or first can be started the calcium channel blocker. But at least patient should be on three these classes, and maximum dose should be prescribed to diagnose the resistant hypertension. Previously, in our study, it was showing about they have a criteria to use the diuretics on the basis of the GFR. So they have mentioned about the patient who has a GFR less than 30, so they use the loop diuretics in place of thiazide diuretics, because they were thinking about loop diuretics has a secreting property that it will help to get the target range of diuretics in the kidney. But this was a change after the concept of the CLIC trial. I will explain about that, what the CLIC trial is that, and why this was the change. Like now we are using the thiazide diuretics, not a loop diuretic, and we are not relying on the basis of CKD stage. So why there's the thiazide diuretics as the first line for hypertension? So there's a lot of studies has been done that thiazide diuretics have an effect on to decrease the mortality of the patient regarding the kidney point of view, heart point of view, and they have the property of the long-acting duration compared to the loop diuretics. And also they have more authentic property of they call the peripheral vasodilation. That is the good mechanism for keeping the thiazide on top of the loop diuretic. So most likely the long-acting peripheral vasodilation and effect of evidence that causes the cardiovascular events are low in the patient with the thiazide. That's why they have preferred to be the thiazide is the first choice compared to the loop diuretics. So there's the CLIC trial that was done in 2021, and it was a randomized double-blinded placebo-controlled trial. It was done in the population of CKD stage 4 and 5, and it was GFR less than 30, and with uncontrolled hypertension, all the patients were diagnosed with the resistant hypertension. So intervention was comparing the clothianidone with the placebo group, and the primary endpoint was to check and change in 24-hour ambulatory systolic blood pressure. Duration was at 12 weeks, and after the 12 weeks, they have to check about 24-hour ambulatory systolic blood pressure. So they have seen keep finding that even though the patient who in stage 4 and 5, GFR less than 3 has a significant reduce in systolic and diastolic blood pressure. So that has changed the mind that previously the people were trying about to do the loop diuretic below 30 GFR and use the thiazide diuretics above 30 GFR. So after the CLIC trial, they are just equally, the patient should be on thiazide diuretic for regardless of the kidney function. So these are the trials that also shows about how the thiazide are better compared to the lubdalzine in terms of cardiovascular events. There was a trial like Alhat trial in 2002 that showed about population of 33,000 adults with hypertension. They have seen the incidence of heart failure are more low compared to the, the long-acting calcium channel blocker and also the ACR of therapy in terms of MI and stroke. There is also the SGFP trial that was done in 1967 to 1970 with the mild to moderate hypertension, and also they checked about the stroke chances are very low compared to the another drugs. The MRC UK trial also in the 1985 and 1990, they also know the thiazide has reduced stroke and cardiac. So all these trials have shown about that thiazide has a more mortality benefit when compared to the other diuretics. So that's why they have preferred to be the thiazide should be a first diuretic compared to the loop or any other diuretics. Right. So, so next, my objective goal is how resistant hypertension affect the different organs. So first of all, the when patient has the resistant hypertension, the wall in the there was a stress on the vascular wall will be high. It will be a pulsate high loading that causes the endothelial dysfunction and causes the oxidative stress and vascular smooth muscle proliferation that causing the remodeling and stiffness and cause the blockage of the artery or veins. So this is the most likely seen microvascular dysfunction have been seen. So I have explained like which organs are most likely affected. Most of the all organs of the body are affected, but most likely I've seen like brain have a small vessel disease that causes a lacunar infarction and stroke-like presentation. And the heart, when we have high blood pressure, there will be an increase in afterload that causes the left ventricular hypertrophy, a concentric hypertrophy. And when there's the blockage of coronary arteries, that also causes the heart failure symptom, arrhythmia, and ischemic changes. As far as the kidney is perspective, kidney has the when they have the blood pressure is high, that causes the high glomerular filtration rate. There will be a high possibility of interstitial fibrosis, proteinuria, and chronic disease and ESRD. Also, with the eyes, they're the most likely the retinal hemorrhages are seen with vision loss and the exudative concentration of in the on the fundoscopy. So this is all from the when they have the vessels. Typically, on the vessel side, there is the atherosclerosis artery stiffness, and most likely aneurysm chances are more high when the patient has the high blood pressure compared to the normal tensor. So this is for just how the hypertension affects on the kidney. So when we have the high blood pressure, it causes the intraglomerular pressure should be high, and it causes the endothelial injury, mesangial expansion. So these are the sequential damage with the high blood pressure. When we have mesangial expansion, thickening of glomerular basal membrane, then obviously we have next line the fibrosis and loss of nephron. So when this renal function is like worsening, there will be a chances of declined GFR, proteinuria, chronic kidney disease, and obviously in the end it will be ESRD. So I would explain like there's a wide variety of causes of resistant hypertension. I have divided it as the primary cause, the primary hypertension and secondary hypertension. So the primary hypertension is most likely when patient has a primary hypertension goes to the resistant hypertension because of the various reasons. Either they have a poor medical medication adherence, there will be a inadequate dose of the medication, not on the maximum dose, and they are not following the dietary restriction, and they have a high chance of obesity and volume overload. This and sometimes with the primary hypertension have underlying secondary cause that is not identified or unrecognized. This is also one of the cause that primary hypertension has unrecognized secondary cause is present with the resistant hypertension. So when the patient who has the primary hypertension always should be exclude the secondary cause regardless of they have history of primary or not. So otherwise, the secondary cause most likely if seen in 20 to 25%. Most of the cause of resistant hypertension is the primary, 75 to 80%. The most likely cause for the secondary hypertension is the chronic kidney disease because it causes the renovascular changes, causing angiotensin mechanism activation, and endocrine, the primary aldosteronism, Cushing syndrome, and pheochromocytoma, and some thyroid problem. Also, the obstructive sleep apnea can cause a sympathetic activation and increase in blood pressure, correction of aorta, and some other medication that should be excluded before diagnosis. This resistant hypertension or but I have seen a lot of patients in my clinic with have resistant hypertension with the drug induced. I have given example in my future slides and will see that. And we have also seen the secondary hypertension most likely from the pregnancy hypertension, pregnancy induced and preeclampsia related. So, because I will explain like three most commonly I have seen the cases regarding the resistant hypertension. I will go with the primary aldosteronism. I will go with the ESRD and primary hypertension because I do not want a lot of coverage regarding the all resistant hypertension reasons. So I will focus on these three. So first of all, I will explain regarding the primary aldosteronism. So let's start with this case. This is I have seen this patient in my VA clinics. So this patient I have seen like 1 year after the I have seen this patient was followed by another fellow last year, and he missed his schedule appointment schedule 2 or 3, and after finally he come after 1 year. So this patient has a CKD stage 3 since last 3 to 4 years, and primary aldosteronism diagnosed 2.5 years or 2.5 years ago. Currently, when I see this patient in the clinic, he was on the amlodipine, losart, and clothiridone. He was not on the spironolactone. When I asked him, "Did you take the spironolactone?" He said he took the spironolactone when he was diagnosed with the primary endo, but his primary doctor had stopped it because primary doctor said his blood pressure is well controlled and he stopped the spironolactone. He don't remember when was the exactly he stopped the spironolactone. So when I just check the workup, I see about renal function as creatinine is 1.3. That is baseline for this patient, and all electrolytes are within acceptable range, but his potassium is on the lower side. That's the 3.1. And I just checked about the PRA workup for this patient. The PRA workup was done the only one time when he was diagnosed 2 years ago, and after that there was no any follow-up on the PRA. So what should I do with this patient? Either I have a 3 to 4 option. Either this patient blood pressure is okay when he come here, blood pressure of 130 is 120, has a CKD function is okay, acceptable. Either I should go with no changes and just a close follow-up on that. And other one is like either I should start the resume of again the spironolactone regardless. I don't have idea what is the current status of PRA. Third one, I can give the like potassium supplements and keep in follow up and check how's going on. The fourth one option is like I should go with the re-evaluation of the primary eldo and decide either this patient has a remission or not and decide accordingly. So I think so the answer will be given in the last slide of the primary eldo. So we'll go from there. So the primary aldosteronism, this is the most commonly seen like in the secondary cause. 15 to 20% I've seen the secondary cause of resistant hypertension is most likely from primary eldo. And this is the autonomic production of aldosterone from the adrenal gland that causes the sodium retention, potassium excretion, and volume expansion. But this is not only the effect of only the aldosteronism on the just kidney. So I have explained how aldosterone work apart from the kidney in next slide. That will give us the idea of what is the importance of aldosteronism on other organs of the body apart from the kidney. So when incidence of primary aldosteronism, I recommend this is the data I collected online. So it shows about when the patient has uncontrolled hypertension, when the stages of hypertension increase, the chances of primary eldo is increasing. So it is seen that stage 1 hypertension, it has in 3 to 5% of people have the primary elbow. When they have stage increase, like in stage 3, there's a 15 to 20% chance of the primary elbow. And in resistant hypertension, we have like a 25% of chances of the primary elbow. So it is good, like I would say, like the patient has the resistant hypertension, everyone should be screened for the primary elbow. So so I have explained like what are the location apart from the kidney has the organ, which organs have the aldosterone receptors. So I will also explain that how can the aldosteronism work in the patient of the ESRD. So this will be give us the good idea how the aldosterone work in the ESRD patient when we don't have a normal kidney function. So most of the organs have the aldosterone receptors, like aldosterone receptors is located in the hippocampus and circumventricular organs of the brain. Also, this the heart and blood vessels have the aldosterone receptors, and the heart and the vessels they have a nitric oxide mediated mechanism, and the cardiomyocyte they have a TGFB mediated that cause the fibrosis. So this I have explained in my mechanism. What is the different mechanism that can be um, act by the primary elbow. So kidney has the distal tubules and collecting that have the sodium retention and potassium excretion. Other also organs have the colon, salivary glands, all have the aldosterone receptor. So what is the primary mechanism that aldosterone act? So aldosterone act like three different mechanisms. One is the genomic classically that have seen in the nuclear bases and with the gene level that takes time to like hours to days. So kidney, most of the function like a sodium reabsorption, potassium excretion, or bicarb excretion is most likely is from the genomic level. Other non-genomic level that is the from because they have the receptors in the genomic is in the intranuclear, but in the non-genomic, most of the receptors are like located on the membrane, and they have worked on the second messenger system. So this also have a second mechanism. Non-genomic have the function in the kidney. It also causes the same effect of a genomic like is increase the sodium absorption and potassium excretion. So I would say like three mechanism are have the interchangeable and can act on the different organ of the body. So they have also the vasomotor effect that causes the vasoconstriction, and endothelial dysfunction is also by the non-genomic. That is a study available that shows the non-genomic most commonly cause of vasomotor constriction and modulation of endothelial dysfunction. And one is about non-genomic that is caused by the nitric oxide mediated. So when we have a non-genomic aldosterone X and causes the CGMP vasodilation, it may affect on the endothelial dependent vasodilation and vascular tone. So these are the three most likely one is the genomic, two is the non-genomic pathway for the mechanism of action or the primary, like a for the aldosterone mechanism on the cellular level. So first of all, how can we diagnose the primary elder? What we are when we are suspecting, what should we do for the diagnosis of the primary elder? First of all, when the patient you are suspecting that this patient that should be really for a primary elder, you have to exclude that first hyperkalemia because the high potassium causes the increased aldosteronism and increased potassium level can cause the increased renin. But sometimes when we have a hyperkalemia that causes the high permeate or high aldosteronism that also causes the renin to drop the renin secretion. So hyperkalemia has dual effect. Either it will cause a high renin secretion or it will cause a low renin secretion. So therefore,
how do normal people get hyperkalemia?
so for
Yes.
there are a lot of reasons like maybe underlying CKD can cause with present with hyperkalemia.
Are they normal? I mean, well, how do you define normal people?
Like percentage wise?
Just in general, what is the definition of normal people here? 'Cause I'm trying to understand how the normal people, get that.
I have no idea how they're coming from.
Please go ahead.
Yeah. So first of all, I have to do the screening test for diagnosis of primary adult. So when we have a 2 to 3, we first of all, we do the blood work to diagnose for the primary elbow. We have to check about the elevated level of aldosteronism, and renin should be a decrease, and also the ratio should be aldosterone renin ratio should be elevated. So when we have a blood work and it shows like aldosterone is more than 10, renin activity is less than 1, AR is the 20 to 30. So patient is not hyperkalemic. This is the all criteria should be met. So this is the positive for primary elbow. But what we are following in the clinic, most likely we follow like if the patient is the aldosterone is high, renin is lower than the like 1 nanogram per ml, we usually diagnose. We have not followed in our clinic the ratio for the diagnosis of primary aldosteronism. So when you have a 3 or 4 criteria met, we do not need to just do the confirmatory test. So when the criteria followed, just this is the confirmatory that this patient has the primary elbow. But if the criteria not match, then we have to do the different tests. So either we can do the saline infusion test. We will give the saline to the patient and see how the patient the aldosterone after getting the saline. Ideally, the patient after getting the saline, aldosterone level should be decreased after getting it. Also, there is also oral sodium load. When we have the primary elbow, we give the oral sodium in normal people. The oral after getting the oral sodium, the aldosterone should be a lower side, but in the primary elbow, it will be not affected. It will be not affected, or it will be still on the higher side. Same about the fluorocortisone and captopril challenge test. So both have the decreased aldosterone, but in the primary aldosterone, when we check it, the aldosterone level is high, not downgraded by all these three, all four. So I don't know which one is the nowadays used in our clinic, but I have seen about saline infusion is most likely used from these four. Okay. So for the management of primary endo, so there's this thing is I have just copied from the Dr. Wiener's presentation regarding the ground round last year. So with uh, with time, there is a change in the target for the primary aldosterone. 20 years ago, there was a saying about control the blood pressure and potassium is the primary target for the management of primary aldo. But nowadays, is the blood pressure and potassium management is not a good thing. So they have also seen the plasma renin should be above 1. So they have did the multiple study on that. So I will explain one of them here and we'll go from there. So this is the data. These are 3 to 4 slides I have just took from the Dr. Wiener's presentation last year. So it has been seen like if the patient who has diagnosed with primary elbow and also the other population of the essential hypertension but no primary elbow, they have the same severity of the blood pressure. It has been seen after controlling the blood pressure in the primary elbow with the same percentage of the essential hypertension in the same range, they have seen like there's the outcome is worsening in the primary elbow patient compared to the essential hypertension. So they have seen AMI chances that reversible ischemia is more higher, like in essential hypertension with the control same level of the primary elbow, it's a 20% MI chances compared to the essential hypertension, 8%. Also, they have seen like a cerebrovascular and TIA chances are more in the primary elbow compared to the essential hypertension is a 3%. And sustained arrhythmia is also like a common, more associated with the when patient has a primary elbow. This is 5 times more in the primary elbow patient compared to the essential hypertension, and CF, the peripheral artery disease, also the 3 times more compared to the essential hypertension. So this has been proved by the study. I will explain this one here. So this is the study has been done. So they have took the patients from the essential, they have diagnosed with the essential hypertension and also with the primary elbow and also with the primary elbow who had underwent adrenectomy. And the blood pressure for all people have the same range with the primary adrenalectomy patient and without adrenalectomy patient. So they have seen what are the consequences if the patient who had underwent the adrenalectomy, non-underwent adrenalectomy and essential hypertension on the long-term effect on the organ. So these patients are followed for 10 years and see how is responding. So the patient who was on the mineral receptor antagonist was 400, the patient who was on the underwent adrenalectomy was 120, and 15,000 was from the essential hypertension. So it has been seen like the people who have the same blood pressure with the primary adrenalectomy patient and primary with MRI therapies, they have seen like with the MRI therapy with the same blood pressure have the high decrease in it's more chances to decrease in GFR compared to the essential hypertension and patient with the adrenalectomy done. It has been seen like chances of curative primary adrenalectomy essential hypertension have the same when patient has the underwent adrenalectomy, but if the patient do not have underwent adrenalectomy and just managed with the adrenalectomy, it has the high chances of worsening of kidney function. In this all we did, they have mentioned that they have never target the PRA activity less than 1. It has been never target in this population. So it's also for the incidence of chronic disease. They have seen about in the primary adrenalectomy that just only MRA therapy is the higher chances of incidence of chronic disease, and if the patient who has the primary adrenalectomy managed with surgery have the least chances of compared to the same as essential hypertension, most likely with the incidence of chronic disease when have adrenalectomy done. This is the study showing about when they have the PRA activity target or not target. So they have seen like with the patient who had the adrenalectomy done, and they have seen like the PRA level is more than 1, and they have the essential hypertension the same for both them. The cumulative incidence of cardiovascular is the same when patient has underwent adrenalectomy, plus they have checked about PRA is above 1. So this is showing about just primary adrenalectomy is not any issue for the blood pressure. It's something more than the blood pressures. So that's why they follow that PR is also a component that should be controlled for the management of primary adrenalectomy. That is not. So I would come back to also the PR also here in the chances of incidence of atrial fibrillation when the patient who has a PRA less than 1, essential hypertension is the high chances. And when the patient has adrenalectomy and essential hypertension have the same chances. So it's all about the PRA activity. When they have PRA activity more than 1, it should be a target for the primary adrenalectomy to get the good outcome for the primary adrenalectomy patient.
So, a couple of questions.
Mhm.
I'm sorry. What was the cause of primary aldosteronism in the adrenalectomy patients? And was it 1 gland, 2 glands? With a little bit of background, if you can, for this setting. How old were the patients?
So I have never detailed how much studies, how many patients were from old are there, but I have seen like target should be if I say the patient who has the primary adenoma, it should be managed with a
In this study specifically.
yeah. In this slide, I have never detailed the vision how many patient was old. I have never seen like
It was adjusted for
yes.
age. I'm just younger people, older people, 1 gland, 2 glands, what caused aldosteronism in them. Just a little bit of background to see how how applicable it is. I do understand it will be adjusted. And I think Dr. Wiener was making a real nice point that younger patients respond better. That's my correct understanding of previous thoughts.
Younger patients have a better chance of cure. They have more of an improvement in their hypertension. That's been clearly shown. As far as mortality benefits, that hasn't been looked at as an independent factor, to my knowledge. I presume in this study that everybody underwent adrenalectomy had a unilateral things because we would not. So presume that it's almost all of them in this study.
Thank you.
After the time period of 20 years, now we have a target. Just this, not only we have to target blood pressure, we have to target the blood pressure, we have to target potassium level, and we have to target renin. And ideally, renin should be a more than 1. It should be good. So once we have diagnosed with the primary aldosteronism with the blood workup, when we should go with the workup by the patient should need electrolyzation or not. It's depend on the patient to patient. If the patient is a good candidate for surgery, I would say that we should proceed with the lateralization and go with the confirmation with the first imaging should be a CT. So when we have the patient in the clinic, so we really ask about from our side that this patient would get benefit from the adenectomy or not. Like if the patient is 90 years old, I would say like to avoid the lateralization because it will be a very hard to go adenectomy and with all the complications. But if they have mentioned about if the patient has the age less than 65 years and the patient wants to do the surgical procedure, so we have to do the imaging and rule out the is either the nodule is there or hyperplasia or there if the patient will get the adenectomy benefit or not. So first of all, we have to do the CT scan and localize the is there any adenoma there. But CT scan did not give us the idea is the functional or non-functional. So if we have a nodule in the kidney, so we have to do the confirmation with the adenal vein sampling. That will give us the idea like this patient has a functional and it should be removed. But main thing about adenal vein sampling is the very hard because of the anatomical position. So sometimes it will be a not a good thing to do it. So we have a new technique that is now the PET-CT. But this has been a very limited availability in the uh, I have not seen that is there available in Shanghai or not, but it's a very rare thing. So and most likely this is a functional imaging and it can identify the without any intervention. So we can do like identify endosterial producing any adenoma, and it is also if the patient has the if you are suspecting that AVS sampling is the not good sampling or it's the AVS sampling did not you are saying about the not a good way taken from, so we can confirm with this type of scan. So for the from management of primary aldosteronism, we have other two managements: the medical management and the surgically management. So if the patient who is surgically managed, we have to follow the PRA activity. If there is a relapse, then we will not start the MRA therapy. But if the patient who after getting the surgery still has a high high just like a chances of primary aldo low renal activity, we will give the also the MRA therapy to surgical patients. So we have a target to control the blood pressure, target PRA more than 1, and also the potassium control. So we have a two currently medication available to treat the primary aldosterone. One is the spironolactone. We start with the low dose. I will really start like 25 mg, and can we go to 50 and 100? And also if the patient who has the side effects from the spironolactone like gynecomastia, menstrual irregularity, erectile dysfunction, and sometimes hyperkalemia. So we can switch to the epinephrine that have a less side effect regarding the gynecomastia and menstrual irregularities. So most likely the primary eldo have the genetic association. Most likely from the most of the time the primary eldo is the familial. Most of the time, primary eldo is from sporadic form. 95% cases of the sporadic form, and 3 to 5% have the cases from the familial. So when we have to diagnose the patient, in which patient we have to do the just genetic testing. So I have seen like I have studied like if the patient who has severely hyperkalemia or who is present at the early stage of 20 to 30 years, so it should be go for the genetic testing. So if the patient who has a genetic test positive, so how can we proceed with the other letters? How can we proceed? So if the patient who has the genetic test positive, and we have to screen the other family members regarding the blood workup only. First of all, if the blood workup is positive, then we have to treat it. But sometimes when we have a specific gene available from the parent, then we can do the genetic testing in the children. Otherwise, there's no need of genetic testing in the children if we have a confirmatory diagnosis with a blood workup, and then we can treat it. Can I do that one?
Control minus. Control minus.
Here.
No, control here on the keyboard. There you go.
Okay, so now it's all about the primary. Though now we have seen the other category, the resistant hypertension, the ESRD patient. So this is the case we have seen in inpatient setting. So this is a 66-year male with on peritoneal dialysis with headache, visual flickers, and blood pressure of 201/81. He had been started rifampin for latent tuberculosis 2 weeks prior to the coming to the hospital. It has been seen that the patient has the non-ST elevated MI, dementia, despite strict adherence to the nifedipine, carvedilol, losartan, hydralazine. So they have started this patient with IV nitroglycerin, and the patient still remained the blood pressure is more than 180. So for this patient, what are the differential causes for this hypertension? So we have seen most commonly with the ESRD patient, we are suspecting that the volume overload is the main thing that we have seen the patient is the ESRD. But this case is the different apart from the volume. We examined this patient was euvolemic. There was no any concern regarding the hypervolemia. So this is the common causes of resistant hypertension in the ESRD. Most likely higher chances with the volume overload, but we have seen a secondary causes of the resistant hypertension, like primary aldosteronism. We have seen a lot of cases. I will give the slide in next that in our here we have a case report that was seen in our primary aldo in the ESRD patient. Also, the sympathetic nervous overactivity and obstructive sleep apnea is the cause of resistant hypertension, and non-adherence of medication or dialysis is also one of the cause of resistant hypertension, drug-induced. So I will explain my scenario. This one is from the drug-induced hypertension. So I will give the details in the next. So how can we just like if the patient come here, how can we decide this patient is a hypervolemia? This is the first thing we have to. I have seen a very problem to just if the patient has a hypervolemia or not. So these are the things that we usually follow the blood pressure, but blood pressure is not good indicator for the volume assistant, volume status monitoring. Also, sometimes we usually do the estimated dry weight, but with time, estimated dry weight will change. So I have one example from my in VA hospital. That patient was admitted with concern of shortness of breath. He has the hospitalization 3 to 4 times with the same concern. And it was documented estimated dry weight of 80 kg. So, and always they usually do like our staff is to try to get 80 kg. But again, he came the same symptoms. So next time what we did, like we tried to just remove more volume compared to the estimated dry weight. So he tolerated the more 8 liter compared to the dry weight. So when we remove the 8 more liter, like is the expected like a weight is 72 kg, and he was doing very well after the 72 kg. And if we are removing after more than 72 kg of the target weight, then he was started the crimping, all the blood pressure was low. So we are expecting that this is from the hypervolemia, and estimated dry weight has been changed. So if the patient has the documented estimated dry weight, we should not rely on the just documentation estimated dry weight. We have to just rule out maybe the dry weight has been changed. So this is the thing we have to do, that there's no any single marker that shows us about the good status of the patient who has a hypervolemia. Apart from this, when we have seen that the patient is a hypervolemia, we should target like how much we should remove. Like if the patient we have a 8 kilogram more, 8 liter more, we remove the fluid just like not a 4 liter in one day. We just remove the 1 liter like in every session, and with 6 to 7 sessions we got it know that the patient has a new estimated dry weight is the 72 kg. that if you are thinking about this estimated driver change, so do not go so aggressively with that. So this is the case report with published. So this is the when Dr. Khizori was a fellow here with Dr. Wiener. So this is the ESRD patient developed resistant hypertension secondary to the primary aldosteronism. This is a 57-year-old African American male with the progressive CKD secondary to chronic hypertension and ESRD. So they did the patient is on multiple antihypertensive medication, but is still they do not have good blood pressure control. So they did the workup for the primary eldo, and the primary eldo workup came back positive. So I have a question, like if the patient with a primary eldo, if the patient with a primary eldo, his kidney is not working, how can the high blood pressure connect? So this is the same when I explained the slide previously that patient have the receptor of aldosterone is just not located the kidney, so all other organs are also affected. Vascular is the one of the more component. So they have this. So we have to start with the same medication, same plan for the primary eldo in the ESRD. We have to treat with the spironolactone and measure the PRA activity. So it has been seen like if the patient has the low PRA activity with the spironolactone, PRA activity increased. So it shows like when the patient who has the ESRD is still the renin secretion is there, and we are following with the renin secretion after getting the spironolactone. So this is the patient that I have explained the primary aldosteronism. How can it act? It's a block the mineralocortical receptor. It's not located on the kidney. It's the blood vessels, brain, and colon. So we have to start the same treatment for the ESRD patient with the spironolactone. Regardless, we think about this patient have a non-functional kidney, but spironolactone can enter other receptors of the body. So third one is I have seen this one is a patient I have explained this one the previously. So what was going on with this patient? So I have presented this case in the abstract for ASN meeting this year. So this case is pretty clear with the drug interaction. This patient was very compliant with medications and he was recently started the rifampin, and after starting the rifampin, his blood pressure was changed. So we have seen like the rifampin can induce the cytochrome P450 mechanism that causes the lower concentration of different classes of antihypertensive. So it has an effect on the carvedilol, losartan, nifedipine, but only in this function if the patient is on 4 medication, 3 was affected by the P450 and only I think so hydrolyzine was only that was not affected. So this is the thing. We have stopped the rifampin on the first day of here on 26th, but as the blood pressure has improved after this 8 to 9 days period. So I have did some studies showing about the rifampin induced P450 has a half-life when the enzyme induced like 7 to 9 days, and it function reverse after the 7 to 9 days, and it will go back towards the hair. It's the 130 and 140s range. So this patient and after that has been discharged. So when the patient has the ESRD with resistant hypertension, we should be think about more than the hypervolemia. This is the interesting case like drug-drug interaction we have seen in the ESRD patients.
What did you replace the rifampin?
Sorry?
Did you replace the rifampin with?
Yeah, so they have replaced with another 2 medication, isoniazid and pyranozamide. I think so. They have replaced it. Yeah, we talked to the ID and they give us the recommendation that. So this is the resistant hypertension due to primary hypertension. So this is the most commonly seen in our population. So this is the 70 to 80%. I think so. 10 minutes are remaining. I will go to the superficial. This is because I have 3 research new drug trials. I will go with that soon. So most likely, I've seen an estimated frequency to the 70 to 80% of resistant hypertension is from the primary hypertension. So they have a trial like if the patient has a primary hypertension, which drug should be a fourth drug? We have hydrochlorothiazide, we have calcium channel blocker, we have ACR therapy. So which drug should be a fourth drug? So they have just did the pathway trial for that. So they have seen about which drug should be the fourth drug for the management of primary eldo. They have seen the comparison of spironolactone with beta blocker, alpha blocker, and placebo. So this is the study they have done about, so they took the 24%, they've seen like already all the patient was on ACR therapy, calcium channel blocker, thiazide, and they have already on the maximum dose. So this study was done in the UK and participant was 314. So every participant has underwent the trial and got all the four medications. So each period was 12 weeks. So if the patient first off getting the spironolactone, then they have a 2 week off of the medication. Then again they have the choose the another medication like bisoprolol, and they are the 2 week off holiday, and then do the third one. They have seen like there was a good outcome. They have seen like how about they have measured the systolic blood pressure in the systolic blood pressure in the office, and they have seen like the patient who have the spironolactone, they have a good outcome compared to the other classes of this drug. So they have seen like when the patient who was on spironolactone, they have checked about the home systolic blood pressure, the primary outcome. So spironolactone has a higher improvement in blood pressure compared to the bisoprolol and the doxycycline, and that's why they have seen about the most likely the fourth drug should be in the primary hypertension should be spironolactone compared to the doxycycline and beta blockers. So these are the limitation for the pathway trial. It's mainly most likely in the UK population, and they have excluded the EGFR this 45 days. So they have just taken the only 3A2 and 2 CKD and 1 CKD. Otherwise, they have excluded the patient who was 3B and 4 and 5. This is the main limitation for this patient, and they have not checked about the long-term effect of treatment. And there was also the crossover. We don't know about the 2 week off period of medication. Still, some of the medication effect is the overlapping the another medication that is patient got it recently. This is the overlapping is also the some of the carryover effect is also limitation for this patient. So they have seen the blood pressure reduction. They have not seen any cardiovascular or long-term effect of this patient, and also the mild hyperkalemia gynecomastia has been seen in the spironolactone patient compared to the other one. So this is the table that what other drugs should be we prefer apart from the four we have treated. We have to choose the first one. So there's no any guideline available. There's no any thing available that we can choose which should be the best one. So it's depend on the choice of the any side effect and what is the attending choice. What is their choice. There is no any concern that we should prefer either alpha blocker first or beta blocker first. It's up to there no any study has been done. But if the patient has the cardiac issues, anything, so we will first start with the comorbidity basis. So it's up to the attending which drug should be started. So this is the new trials that has been recently going on. So the trial, I will explain the first one. This trial is just FDA approved 3 days ago. And this is a study that has seen about aldosterone synthase inhibitor in the resistant hypertension. So they have take the sample with they have taken the people with the resistant hypertension and see about how the lorundrostat is affecting the hypertension. So they have just the endpoint is just check the office systolic blood pressure at the week of 6 and versus the placebo. So they have 4 groups. One group have got the placebo only, no drug, and the second group have got a 25 milligram of lorundrostat, and third group is taking the 50 mg, and fourth group is 100 mg. So in the background, this patient, all our patients with the 2 antihypertensive medication, and some of them are 3 antihypertensive medications. So it had been seen like, 3 drug regimens was taken by the 37% of the people, and 2 drugs was seen by the 63%. And from the total of 174, 61% was using the endopamide, then the hydrochlorothiazide. So a study has been seen like it has a drug-based effect, the dose-dependent outcome of the lorundrostat. They haven't seen like the patient has 25 milligram of drugs, it has 9.3 improvement systolic blood pressure. And if the patient is on 50, there was 14.7. And if in the hundreds, and this are all are on the dose dependent manner. So in this population, they have taken the sample from the primary adolescent patient, but it was not target to check this patient either can benefit from the to treat the primary adolescent or not. But they have seen like the patient who has a primary aldosteronism and they have the low PRA activity, but after they check the end of trial, they have improvement in the PRA activity. So this may be a drug for good for the primary aldosteronism. So they have just started the trial to check of the primary aldosteronism efficacy with the lorundrostat. I think so. It's a new trial is going on. The how can we is there lorundrostat is effective in the primary aldosteronism or not? So it will be a debate either if this approved by the FDA for the primary aldo, either we should prefer this drug or we should follow with the same spironolactone or eplerenone, because I'm thinking like it will be a more costly compared to that. But if there is approved, I think so it will be a good option for the resistant hypertension, and if the patient not responding to the primary like with the spironolactone eplerenone, then we can try this one. But otherwise, the first line I think so spironolactone and spironolactone would be a good. So this has the previously I just came to know early in the morning this patient this has been approved by the FDA. So this was presentation made by a few days ago, so that's why I did not remove it. But now it's the FDA approved. So previously there was another class of this drug is the osilodrostat that was also aldosterone synthase inhibitor, and it was seen about this has the loss of specificity. It also affect the production of cortisol production. So this is the non-specificity. It's also the inhibit the enzyme of cortisol production apart from the aldosterone synthase inhibitors. So that's why this was I think short trial was not continued. So another trial I have seen like baroreceptor activation in the hypertension management. We have seen like a patient who has a baroreceptor activation. How can we just improve in the blood pressure? So they have taken the sample with the resistant hypertension 3 to 4 drugs, and they have mentioned about by putting the baroreceptor activation devices and see about how the blood pressure is improved after 6 months. And the primary endpoint was 3 months, and they have seen like the people who was on the baroreceptor activation has a good improvement, like a 21% decrease, then 21 mmHg blood pressure decrease compared to the other one is like 11.7. So this is also the one with the patient who's not responding very well to the resistant like to the medical management. Then we can think about there's a pros and cons. The pros and the cons. Pros are that this patient has improved the blood pressure and also well tolerated with the least common side effect. But this is the invasive procedure. So I would say like it always just can be used for the patient who's not responding to the drug therapy. Then they have used this one. The third one, this is the last one. This is the for renal denervation for. So this is also, I think so, the study is also going on some other units here also, they are doing some study. So they have seen like the patient who can benefit from the renal denervation. They have seen like if the patient has a renal denervation, they have compared with all of the patient who have underwent the maximum therapy antihypertensive medication, and they check the renal denervation. And they have resulted that renal denervation also has a timely manner improvement in the control of blood pressure. They have seen like at the 2 months, 8.5 mmHg improvement in systolic blood pressure. And in the 6 months, it was seen 11.3, and the 12 months, 11.7. So this is a study is still going on. So what are the long-term effect of renal denervation, and how the one-time denervation effect, like it's a 2 year, 3 years, but the study is still going on. Thank you.
Thank you. That was great. In the interest of time, those who have questions, we can come to you personally. That was really great. Thank you.
Thanks.
You're a tough crowd. We also ask, quick trial, 60% of patients were on. So people want to start with the results. It's some conventional group, it's not basic. Yeah, yes, that's it is a basic.
About the research. So I've been trying to organize myself on like what I'm gonna do when I leave Puerto Rico, and I would like to participate in this ad coordinator, which I think I mentioned. So I was wondering if I could meet up with you and Maggie to kind of like get a better idea. Okay, so when is the next?